Thank you for being here. I'm here with Dr. Connor Dixon, who's a sports medicine um, attending, who I was lucky enough to meet in, where were we? San Francisco.
Yep, of
So,
course. Thanks for having me.
so we're going to talk today about low back pain, which is the pain of my existence in the emergency department.
You're not alone.
Everybody, yeah, everybody has low back pain, and I never know what to do about it. It's kind of a frustrating problem because it's very common and it's very hard to sort of help with. So we're going to talk about that today, and you're going to teach me kind of how I can think about this in a better way and what I can do to help these patients. So yeah, let's just get into it. So maybe you could tell me just a little bit generally about the epidemiology of back pain.
Yeah, so I mean, I'm sure as most people who work in any emergency department know, it is not an uncommon presentation or presenting illness or complaint for most patients. There have been several studies looking at sort of the overall prevalence of this, but long story short, it's in the top 10 like total reasons for people to visit the emergency department. So no matter what you do or kind of where you're working, what position you're in, you will be seeing people who are presenting with some sort of low back pain. And for those who are in training or those who've been out for a while, you've seen this many times. And I think that our training does a pretty good job of teaching us how to identify the scary things for back pain and think of all the emergencies. But part of my sports medicine training has really given me the knowledge to be a little more specific about the non-emergent causes of back pain, which frankly are the vast majority of the people that we see.
I love that. Before we get into the bulk of who actually has back pain, let's really quickly run through some of those red flags that we look for to figure out who has those real back pain emergencies.
Yeah, for sure. I mean, I think that's always the important thing with emergency medicine is our jobs are first and foremost to rule out the emergencies. But just to kind of refresh and review some of the things that should be triggering sort of a warning sign in your head are things like patients having bilateral lower extremity neurologic symptoms. So, a lot of causes of back pain, such as radiculopathy and other stuff that we'll talk about, can give you sort of unilateral symptoms like numbness or tingling or even weakness. But anytime you have bilateral, it should be something that you're thinking about and a little more concerned about for something like cauda equina. You can have bilateral radiculopathy, but it's a little more rare, and you just need to think of the emergent things before that. Something that goes along with that is sort of the saddle anesthesia or having bowel or bladder issues. Again, these are usually drilled into our heads as like, oh God, cauda equina, make sure you're thinking about this and or ruling it out. And then part of your sort of exam findings that you can do to evaluate for this a little more is obviously doing a rectal exam and looking for rectal tone and or doing a post-void residual. And then kind of going more towards the infectious route, any history of fevers with low back pain should obviously be concerning, history of IV drug use, and then the more vascular-based things, history of vascular pathology, so people with CAD, peripheral vascular disease, be thinking of like dissections or AAAs in the belly that can often cause this low back pain. Anytime you have back pain with syncope as well is something you got to think of. And then obviously on exam, if you have like a pulsatile abdominal mass, that should be pretty scary for most people.
Not good. Yeah.
Yeah. And then lastly, just more from like the trauma perspective, again, we're pretty good at figuring this part out. But if there was recent trauma and they have like midline tenderness, of course, you're thinking more along the lines of an acute fracture or something like that.
Great. And recent procedures, I think you mentioned also,
Yep.
yeah. So, and
Yeah, it's something we may not think about a little bit with that too. Is just if they've had a recent spine surgery or anything, you can get kind of post-operative hematomas and things that can cause spinal compression as well.
great. So, I mean, and yeah, I agreed. Like, okay, so if you see any of those things, um, then you're going to be ordering some advanced imaging. You're going to be worried, and we're going to do our emergency medicine thing. But let's say all of those are normal.
Right.
Now, what do we do?
So yeah, I mean, this is where I think I was really happy I did my sports medicine fellowship because most of the EM training sort of stops there. They're like, great, either you did imaging and it's all negative, or you just kind of convinced yourself and the patient that okay, like nothing dangerous is happening. So now what? When most of the time, most people are saying like, all right, well, maybe this is a muscle spasm, maybe it's sciatica, but hey, here, take some pain medicine. Hopefully you feel better. Go see your doctor. Good luck. And that's where a lot of the sort of emergency medicine training ends. And thankfully, I think that there is more that we can offer our patients, especially in this day and age when it really does feel like for most systems out there that people are having a very hard time getting into their primary care physicians, and it's taking weeks to months sometimes to get follow-up appointments, let alone go see like orthopedics or a sports medicine doctor.
Right.
So there's a real opportunity for us to be a little more specific in what we tell patients, and even trying to get them on the right track for their treatment from the emergency department while they're waiting to see their primary or specialist outpatient. So I think that I kind of break things down into three main categories, and we'll sort of talk about those in a second in terms of like non-emergent muscular back pain. I This is by no means like something that's specific or has been put out in the literature. This is just more of my way of thinking of things.
Great.
But first, I think that part of what everybody should be adding or thinking about to their regular exam is a little more of a nuanced and specific exam for back pain in general. So most people are obviously doing like palpation and inspection. If there's no history of trauma, like most people's spines are going to look normal, of course. And I'm pretty sure every single person is obviously palpating midline spine for like any sort of back pain etiology. That's just part of ruling out some of the emergent things. We're all almost always palpating as well the sort of paraspinal muscles, which most people again are aware of. Like, okay, is this a muscle spasm? Does it hurt when I push on your muscle? So those are some important things to start off with, and then just really paying attention to if you feel something called like trigger points, which are essentially knots in the muscles or focal spasms. Obviously, if you poke on it and push there and it hurts, that's a pretty good indicator that that might be the generator of their pain. Um, Again, part of the overall exam to help rule out emergent pathology is a complete lower extremity neuro exam. And I think that's where most of our kind of basic exam ends. But something that we can add to this is sort of a lot of range of motion testing, which with kind of provocative testing built into that. So flexion and extension of the spine are kind of the two major things, obviously like bending over and leaning backwards. And then something else that we kind of frequently do from the sports side is sort of like rotation and side bending. And this depends on who you talk to and what they call it, but I kind of call it facet loading for the most part. And facets are like your spinal facets where each vertebrae kind of articulates with itself, or with the one below it and above it. And there are major stabilizing points for each vertebrae in the spine, but they also allow it to flex on itself, and they're like rotating as part of a joint there. And again, we'll talk about in a second kind of certain exam findings that can point you one way or the other, but just kind of testing all of these things to see if one specific range of motion is causing more pain is also extremely valuable in sort of getting a little more specific in your diagnosis. And then the last one that I think is just helpful to know, there are millions of other things you can add, but just a straight leg raise. Most people know this as well, but it can sort of point you towards a radiculopathy diagnosis if it's positive.
All right. So yeah, that sounds great. Let's get into different types of non-emergent back pain that we might have.
For sure. Again, this is mostly just how I think of things, but I break the different types of pain into three main categories. So there's muscular pain, there's something I call like structural pain, which includes arthritis of the spine, or like discogenic pain, as we call it. It's like a herniated disc, which can sort of just be a pain generator in itself. And this is sort of excluding fractures, of course. And then neurogenic pain, which is more of a like radiculopathy, or what people call sciatica all the time, and spinal stenosis are sort of the main generators of pain or main diagnoses that would cause neuropathic pain or neurogenic pain.
Okay. So just to go over that again, so muscular pain bucket is some sort of strain with the muscles, the paraspinal muscles.
Yep.
Your structural pain, you're saying there's something actually wrong with the vertebrae, the discs. Not like a complete fracture, obviously, but maybe some arthritis or some herniation of the disc or something like that.
Yeah, exactly.
And then neurogenic pain, you're saying like there's some nerve related pain that is presumably peripheral nerve. It's not the spinal cord itself.
Correct. Yeah. Spinal stenosis kind of overlaps with that a little bit, and that's depending on the degree of potentially emergent diagnosis. But most of the time, when you're seeing people and you've kind of ruled out the other major things, it still kind of falls into this non-emergent category that can cause pain.
Okay.
So yeah, so kind of muscular pain. That one's the easiest for everyone, I think, as well. The typical exam is going to be basically what we all do anyway. You know, you palpate the midline spine, assuming that there's no pain there. Most people are going to palpate over the paraspinals. If you are feeling, like I said, a trigger point or a knot, so just like a nice little ball of tense muscle, and that reproduces their pain, then that's a pretty good indicator of that's what's causing it, and that's pretty simple for most people. They'll also have pain with range of motion, mostly just because the muscles are stabilizing, of course, the spine and kind of helping it move. And so if you're activating those muscles or stretching them, they're going to hurt as well. And I think everyone is pretty comfortable with the muscular pain, but what we can do to sort of help it and treat it more specifically from the ED is part of what we'll talk about later.
Great.
So structural pain, this is where I think we can get a little more specific and helpful for patients as well. So, you know, kind of this arthritis, discogenic pain, herniated disc category, that can cause pain just like in the spine itself. So typically, because you're not actually being able to touch the joints or touch the discs because of all the soft tissue and the other kind of bony structures in the way, you're not going to have specific point tenderness. You know, you can't make it hurt just by touching it from the outside. So really what you're looking for is pain with specific range of motion or specific kind of provocative testing. And so, like I talked about a little bit earlier, the easiest and quickest ones that give us the most information in the emergency department, I think, is this flexion extension and then facet loading, which is sort of like a side bending rotation. So the flexion extension is easy. You know, flexion of the spine, I just ask people to like bend over and try to touch their toes. And I ask like, does this cause any pain or does this relieve your pain, et cetera? And like, where do they feel it? Extension is also very simple. You just ask them to lean back. I usually put my hand on people's lower back and stabilize them, and then like put my hand on their shoulder and sort of guide them back into extension.
Okay.
And then facet loading is sort of a broad term, but what you're doing is you're trying to put specific pressure on each of those articulating facets between the vertebrae. And so the easiest way to do this is I have people sort of plant their feet and they're standing up when they're doing this, and they plant their feet and you rotate them one direction, so either right or left, kind of twisting at the waist.
So kind
And
of like
then,
this.
yeah. And
Okay.
so, and then you sort of lean them back as well. So they're twisting one direction and then you're leaning back, almost like you're reaching behind you to pick something up off the floor.
Okay. Gotcha.
And then again, I usually sometimes guide them. I put my hand on the back just because sometimes it's really hard to describe that to people. And so I just sort of guide them into that position to see if they have any pain with that. And then I usually do it on both sides. Sometimes you'll get people who are like instantaneously like, oh, yep, nope, can't do that. That's what hurts it. And so you don't even really have to go into the full, maneuver, but other times you do. And so you just kind of see where you end up with that. So typically for a structural etiology of pain, so whether it's like arthritis or disc pain, for arthritis, you're actually putting pressure on those joints. And so it's mostly going to be pain focally in the back, like on a specific spinal level or a couple of them with that facet loading, with that rotation and backward bending. And sometimes they'll have it on one side, sometimes they'll have it on both, but it's pretty remarkable because most patients, you're kind of like, hey, sorry, like I'm going to try to hurt you. And then you do it and they're like, oh God, yeah, that is what kills me.
Mm.
And that's a pretty good indicator. Like, okay, I'm pretty sure this like has something to do with your facets, your facet joints. And then from like a discogenic perspective, it's like a herniated disc, not really talking about the kind of pinched nerve part, which we'll talk about next, but you can just have pain from the disc itself. And that is usually elicited more with the extension of the spine.
Okay.
Just because if you think about, I guess we don't have a photo, but if you think about, the spinal joints kind of sitting on top of each other with the disc in the middle, as you're bending back, it squeezes sort of the back there. And if you bend forward, it sort of opens it up a little bit.
Okay.
So bending back will kind of squeeze that potentially irritated or herniated disc and usually generate a little more pain.
And then what about the leaning forward one, the flexion?
So flexion is typically it's not going to cause pain for any of these. There are a few really specific conditions where it might, but for our purposes and kind of for these general categories, most of the time the flexion is actually potentially relieving pain. So it's kind of good to say like, okay, does it hurt when you lean back? What about when you lean forward? Oh, the pain's better. Okay, that kind of indicates that it's something to do with the extension component.
Okay. So just to summarize that with these exam maneuvers, leaning forward, generally we're looking at if it is a structural issue, may relieve pain. Extension may increase pain if we're talking about a herniated disc, and facet loading by rotating and leaning back will increase pain if we're talking about like a facet arthritis type of picture.
Yeah, exactly.
Okay.
Um, the key point is that the pain that it generates is all located in the back. You don't have any sort of radiating pain down the legs or any numbness or tingling. It's just, oh, this hurts in my back in that one spot.
Right. And theoretically, if it was muscular pain and you were to just muscular pain, you were to do these exam findings, it wouldn't increase the pain.
So that's sort of the tough part. Is it depends, because again, your muscles are all doing the stabilizing and the moving. So I usually start with the palpation component, of course, before the range of motion, because of it almost always, I guess, like you can't say always for anything, but typically for muscular pain, it's going to hurt over the muscles. Like you can
Okay.
touch that. And so the range of motion will probably make people feel worse. Nobody really wants to move when their muscles are spasming.
Gotcha.
But usually it's like, oh, okay, yeah, I can feel it. And most people, again, are pretty good about saying, like, oh, yeah, it's in the muscle, like right here. The
I
vast
see
majority of
that.
people can identify
So
that versus something
if that was
else.
the case, you would sort of stop there because now you've got it's muscular. But if that doesn't, if you don't get any tenderness there, now you're going to do some of these provocative maneuvers to try to elicit.
Correct.
I
Yep,
understand. Okay.
exactly.
Okay.
All right. And then lastly, so the neurogenic pain, the nice thing is the exam maneuvers are identical. You're still pretty much doing the same exact thing. You're still trying to do facet loading. And then you won't have specific tenderness. Again, you don't touch the nerves or you can't compress them just by poking from the outside. But the same sort of exam maneuvers can also provoke the pain. The only difference is in how you isolate it is, okay, so for structural pain, typically the pain is like located right in the back and doesn't go anywhere else. For neurogenic pain, you get that radiating pain down the leg typically, or like down lower in the back, and or you might get like numbness, tingling, paresthesias with it as well. So you'll do these same exact maneuvers. I start with palpation, no muscle tenderness, no midline tenderness. Okay, let's do some range of motion things. And then I'm saying, okay, well, oh, does this hurt you? Does facet loading hurt you? Where does it hurt? Is it only in the back, or does that shoot pain down your leg or give you numbness, tingling? And that's what kind of indicates whether this is more of a nerve compression issue like radiculopathy or radiculitis, or spinal stenosis if it's more like the extension. So typically for radiculopathy, this can come from a herniated disc as well. But if the primary pain is, oh, it starts at like my low back, goes down my butt and down my leg, and with a little bit of tingling, whenever you do their like side bending and facet loading, you go, okay, well, this is probably putting a little more pressure on the nerve as that maneuver also narrows the neuroforamen that where the nerves come out of. And so if you already have stenosis or compression there, it's just going to make it worse. And
Just to
so,
take a step back, you mentioned side bending. I don't know if we specifically, if how does side bending work? I don't know if we specifically talked about that.
yeah, sorry. I guess I throw it in side bending, like you're sort of side bending and rotating whenever you're doing facet loading. So like
Oh, okay.
true to side bending is just this, but it's less compressive than like the rotating and side
Rotating.
bending. So it's
Okay.
like a extension, side bend, and lean back whenever you're doing a facet loading.
Okay. Okay. So you're saying in the neurogenic situation, if you're doing this side bend rotation facet loading thing and it's causing a radicular pain down one of the legs, then what does that mean?
That is more suggestive of a true like radiculopathy or compressed nerve, and that
Okay.
again is just a little more specific versus, oh, there's just pain in the back.
Okay.
And that's how I sort of try to put them into these two different buckets of like, okay, well, you clearly have some nerve irritation going on, or oh, it's just located in the back. It's probably not the nerve because that typically gives you the radiating pain.
And then if you do extension, just going straight back,
Mhm.
and that causes pain radiating down one or both legs, what are we talking about there?
So that is suggestive of spinal stenosis, and so you can have critical spinal stenosis or mild, and that is only really able to be determined on an MRI. But that is more of the like, okay, you have some canal narrowing, and it's starting to hit some of these peripheral nerves that are just taking off from the spinal cord, and so you can have compression, essentially the same thing as radiculopathy, and it is still kind of a radiculopathy. It's just compression in a different area.
Okay. So the question for you is like, where does straight leg testing play into this neurogenic bucket that we're talking about?
Yeah, it's really an adjunct. I don't use it too much anymore. Sometimes if it's like a little more confusing, like, oh, did that go down your leg? Like, did this pain go down your leg with this sort of range of motion maneuver, or was it really mostly in your back? I just add it as like another tool in the toolkit to try to be a little more specific about it.
So, but are you saying that because the straight leg testing is just not really that great for anything, or like what are your thoughts on straight leg testing specifically?
So every, long story short, every one of these like provocative tests and exam maneuvers have like moderate to poor sensitivity and specificity. So there are the ones that I use kind of more frequently because I think it gets you the most bang for your buck in a very quick amount of time. You can do a very thorough exam, and there are like, I don't know, 10, 15 different maneuvers just to look for radiculopathy that you can say, like, okay, if, seven or eight of these are positive, that's highly indicative of that.
Well, maybe we could just talk through the straight leg testing only because I know that's something that we talk about a bunch anyway. So maybe you could just tell me like how does that work and how, should we or do you think it's something we shouldn't even be doing?
I think again, I do it just as an adjunct afterwards. Like, okay, hey, I did all the range of motion stuff, the palpation, and I wasn't sure, or I'm not convinced that it's sort of one thing versus the other. So I just asked. I mean, you need a bed for this. Unfortunately, you can't do it for people in chairs. The nice part about the other stuff is that you can take someone from the waiting room, roll them into any space real quick, and just say, hey, like, let's just do some range of motion, palpation, that kind of stuff. Plus, you've already walked them then, and you see that, like, okay, you clearly can walk. And you can do all your exam from a chair essentially for that. But for a straight leg raise, you do need a bed. They do need to be lying flat and have enough room to then lift their legs up, or you're lifting their legs up. But really, you just take one leg at a time, and you, as the name suggests, you lift it as a straight leg. You ask them to not put any muscle tension on it at all. They shouldn't be resisting you or trying to help you. It really should just be like a dead leg in your hand. And I just grab at the heel and depending on your strength or whatever, you might just have to position your body and however big the person is, but you lift up their leg just at the hip. And so the knee is straight and extended, and you're lifting kind of at the heel from the bed. And then usually a positive test is somewhere around 30 to 40 degrees I guess that would be hip flexion, that you start to have pain elicited either in the back or radiating down the leg. The straight leg raise is mostly designed for kind of radiculopathy. I don't know if only getting pain in your back actually suggests like more of a structural problem or a muscular problem. But what you're looking for as a positive test is, oh, does this shoot pain down your leg, as in like a radicular pattern? And that would be considered a positive. And the, I guess, fun or interesting part is that you can have a positive straight leg raise, but like on either side. So if you have sort of right-sided symptoms, I could raise your left leg, and that would still give you pain down your right leg sometimes. And or obviously lifting the right leg can give you pain down the right leg as well.
Oh, interesting. Okay, so that would be another way to possibly look for radicular pain,
Correct.
just like the facet loading by rotating and leaning back would do.
Correct. But if I get like this nice clear, oh, okay, I rotate back, I facet load somebody, and they're like, oh my God, it shot like pain and tingling down my leg. Like, I don't really need that straight leg raise. Sure, if it's positive, yeah, it helps. If it's negative, it's still, I'm not thinking like, oh, maybe this is not radiculopathy. I just kind of stopped there. But if I do the facet loading and they're like, yeah, I don't know, it kind of hurts, maybe it does, maybe it doesn't, and you're just like, okay, well, nothing seems to be triggering it. That's when I start to add a couple other of these exam maneuvers to see, like, okay, maybe something else will provoke the pain and kind of give me an idea.
And one thing you mentioned was that you were making a distinction between sort of sciatica and radicular pain. Is just sciatica just like a term we shouldn't be using?
Yeah, technically, yeah, that doesn't even exist. It came about, and it's funny because it is like an ICD-10 diagnosis. But it came about just from the fact that like the pain typically follows the tract of the sciatic nerve, but it's not that you are pinching your sciatic nerve. It's you're pinching the nerve roots, and several different of the nerve roots contribute to the sciatic nerve, but it's not like all of them do, or they all do to some degree, but it's not like you're pinching only the sciatic nerve.
Got
So
it.
the more specific term is radiculopathy, or radiculitis.
Great. So let's move on from there. I think maybe the next thing we could talk about is imaging. We don't often, we don't really need to do much imaging in ED as long as there were no red flags like the ones you mentioned before. But let's talk through some of those images and see, what could they potentially show us.
But X-ray, so it's got a very poor sensitivity for fractures. So if we're just talking about like kind of the acute evaluation of, if you're thinking maybe doing X-rays for a traumatic injury or anything like that, for the vast majority of people, you cannot stop at X-rays if they have pain and you're concerned about a fracture. But they are exceedingly useful for kind of arthritis like pain, and they can. That's how you kind of are identifying arthritis is through X-rays.
Are you sort of seeing like you're seeing the things you would see in normal arthritis, like sort of erosion of the joint surface, maybe some of those joint mouse things between vertebrae or something, or
It's a little different for the spine because they have the discs in the way, so there's less erosion. It's a little bit different than typical. So unless you're sort of used to seeing those or looking for them, it can be a little harder to find.
okay.
Typically, a decent indication is something called end plate spurring. So if you look at like a lateral X-ray of the spine, and you see like each kind of block like vertebrae, they'll have little like spurs coming off the tip. So
Okay.
that's kind of one of the major indications of that. And then even I have a trouble seeing this, but you can actually see like facet arthritis on X-rays. It does look like a little bit of blurring of the kind of joint space and a little bit of sclerosis around them. But also, what's helpful is something called spondylolisthesis. There's like a whole spectrum. So spondylopathy is just the kind of arthritis of the spine. Um, Spondylolisthesis or spondylolysis is essentially a break of the pars interarticularis, and this is kind of getting into details, but you can see that on an X-ray. And then listhesis, spondylolisthesis, is when the vertebrae actually slide on each other. So if you got your vertebrae like this, or looking at it from a side angle, it's when they're kind of I don't want to say dislocated, but sort of sliding either anteriorly, posteriorly, and that's due to the break in the pars, which is what stabilizes each vertebrae upon itself. And if you can think about obviously the sliding of it, you can get some spinal cord compression or you can get nerve root compression. And it just sort of depends, and you'd have to get an MRI to see exactly what is being compressed. But X-rays can be helpful in seeing all those things. It's quick and easy, and you can kind of align the spine and figure out what's off and what's not. So yeah, so CT, again, for the vast majority of the time, you're never going to really need it in ED. The only time I think it's useful is for like looking for acute fractures. You absolutely should be getting them if especially if they're elderly. But anybody who's got significant back pain after a traumatic injury, again, the X-rays are just not sensitive enough to catch some of these major risky fractures. So you really do need a CT, and their sensitivities, whatever, 98% or something like that. So
Yeah.
that's really the only use for CT for back pain. They can't see nerves. They can't see sort of like the radiculopathy thing. They can somewhat see arthritis mostly just from the spurring, but it's actually harder for CT to pick up on like the facet arthritis as well anyway, but you should never be ordering that just to look for arthritis. And then MRI is, again, very helpful, very hard to get and expensive for most EDs. You really have to be thinking like, okay, there's a serious problem to get it. And that's mostly for your like cauda equina rule outs or spinal epidural abscess, that kind of stuff, which in that case, you absolutely should be getting it. And I guess, sorry, just as an aside for CT, if you have someone who can't get an MRI for, whatever reason, metal, pacemaker stuff, the next best test will be a CT myelogram to evaluate for like cauda equina or spinal epidural abscess. It's not as good, but it's not terrible for it, and generally is accepted if it like is negative. But then MRI from like the outpatient setting when we do it, which is obviously not going to be in the ED, but is super helpful because then you get to see every vertebral level, every detail. You can see every nerve root individually. You can see the spinal canal. You can see where the spinal canal ends and the cauda equina begins. You can see every disc and whether it's bulging, and you have all that detail that tells you exactly what's going on. You see arthritis very well. You can see stress fractures really well. So it's really the gold standard for pretty much any other sort of cause of back pain. But again, it's kind of a whole story together because even if your MRI is showing nerve root compression, but they have no pain or radicular signs, then like it's not really radiculopathy. It's just you have that finding, and that happens all the time.
Hmm.
So everything is taken in context with the presentation and the exam.
Right. Okay. Cool. So we've talked about red flags. We've talked about interesting exam maneuvers that we can try. We've talked about imaging that just so we understand what different imaging can offer. Let's talk about treating this.
So this is the best part about it is we can do a lot of help for our patients just by getting more comfortable treating this in the, I guess, medium term, not short term. So like short term is okay. Hey, you got pain today. Here's your pain meds. Hope you feel better. Go home. Maybe have a prescription for whatever, a muscle relaxer, whatever. And that's where like a lot of our training and a lot of our typical practice ends. But depending on your setup and your system and what kind of access you can give people, you can do a lot better than that, I think, to help a lot of people out. So, the mainstay of treatment is going to be everything that we already know, including Tylenol and NSAIDs. Ibuprofen is the easiest one, and we're pretty familiar with it. I think most people also know naproxen relatively well, Aleve, and they're relatively comfortable with that. But I know through my ED training, that was kind of where I ended, or Toradol. Like those three NSAIDs are basically all we ever really touch. And we hear about other things. We see like Celebrex, Saloxib. We see, sometimes we see meloxicam. Sometimes we'll see Nebumetone. There's a couple other ones that like maybe we see from the outpatient setting, but it's not like we ever really are prescribing them that often or giving them to people. And so I think, one thing that people can do, and that's a whole different discussion itself, is just kind of become familiar with a little more of like the long-term NSAID use, like what people in the clinic would be giving their patients, because there's not really any good reason that we shouldn't or can't be giving that to our patients as well. So like I really like meloxicam. It's one pill once a day. Yes, long-term use of any NSAID will increase your blood pressure or will cause some small amount of kidney injury. But the good news is the ones that they use in the clinic are kind of designed to one, not do that as much as like ibuprofen or Aleve. And there's actually a whole list of like the different effects of different NSAIDs in terms of like which one does what. But for like a 2-week course, you're essentially guilt free, like except for some stomach upset and except for those major contraindications. You're not going to raise anybody's blood pressure to any significant degree. You're not going to cause any significant kidney injury unless they have something else that happens. So we can prescribe these people 2-week courses, 3-week courses of these NSAIDs without really thinking too much about what it's going to do to the long run. And I just do that. I don't give them 30 pills. I literally just give them like, here's 14 pills. You're taking one a day. You cannot take more than this without talking to somebody else. And I think that really helps kind of in the long run deal with a lot of their pain, because we sort of leave them with this ibuprofen, which if they do slam that down is actually worse for them than taking, meloxicam or some of these other longer term ones.
Gotcha. Okay, good. That was great. Yeah. So NSAIDs mainstay there. And if we're doing short course, it's not the end of the world. I mean, we know the side effects are there, but we're talking about the acute setting here.
Correct. Yeah. Well, any long term use, all these studies usually are talking about like a month or more. So you're pretty safe for a short 2-week course.
Okay. What else?
So we always use Tylenol as well. I mean, I think hopefully most people have heard of the studies for like acute musculoskeletal pain, that the combination of Tylenol and ibuprofen together is actually about as efficacious as morphine. And I pull that card out with patients all the time, especially when they're asking for opiates, just to kind of try to seal the deal. And I think it works for the most part. But everybody knows how to use Tylenol, so I always add that in no matter what, unless again they have some sort of specific contraindication to it. And then the next line is, okay, we usually are talking about like lidocaine patches, right? We use some sort of numbing patch or numbing cream, depending on the situation. The unfortunate part about it is that actually the studies looking at true pain relief from various kind of musculoskeletal lower back pain, non-emergent things, non-vascular, et cetera, they don't really do anything in terms of an actual objective improvement of
Okay.
pain scores. But that being said, I think that it has a decent amount of value as a placebo, and it's definitely not going to hurt people again. For muscular kind of things, it might be a little more helpful, but even the studies for that really don't show improvement. But I still give it to everybody because, again, I'm like, oh, we're going to give you these like 3 or 4 medicines, and it's the combination of everything that makes it better.
I
Because I think,
swear by that. That's
yeah,
okay.
and who might have said it doesn't work? Because placebo, if you feel better, still works.
Right, right.
Um, and then I think a lot of other people also talk about, muscle relaxers. So what are like, do you have some muscle relaxers that you typically use or that you're familiar with?
I mean, we love giving out, Robaxin, Flexeril, I think are the two that I've used, but
Yep.
I've had some attendings say, if you're doing that, you might as well just give Valium instead. Works
So
just
yeah,
also.
almost every single like muscle relaxer that's in that category, which you named a few. There's other ones like tizanidine, baclofen falls into that, and a couple other ones. But a lot of the benzodiazepines are also considered a muscle relaxer as well. Valium kind of being the more specific one for muscles. The data shows, and like the actual pharmacology of it, it doesn't touch, the vast majority of them don't actually touch any sort of peripheral muscle receptor or neurologic receptor at all. It's all centrally acting. And so whether you want to say, okay, well, is it actually relaxing your brain's activation of a specific muscle is quite questionable. And I don't think there's any way to prove that it is or it isn't from that regard. But
Okay.
they almost are all centrally acting. So in reality, when you're giving a muscle relaxer, you're giving a brain relaxer for the vast majority of these. Now, the
Right.
interesting thing is Valium and baclofen are the two exceptions to this. There is theorized to be some sort of peripheral activate, like receptors for these drugs that it works at. They don't really know how or what it does, but those are the only two that may actually do something like at the muscle, which is kind of interesting.
So Valium or baclofen. Interesting. Okay.
Yeah, and so I
If you're
mean,
gonna give it, I just well give one of those two.
there's the obvious concerns with benzos, but any sort of muscle relaxer as well has some decent anticholinergic effects. That's why all of them sort of make you drowsy, or benzodiazepine GABA effect. So you're going to have to just be cautious with your patients who are over 65, kind of your beers, drugs kind of sort of list or whatever, or anybody for that matter who is kind of more prone to delirium or people who have like maybe psychiatric or behavioral conditions, et cetera. I would just think kind of long and hard on like, okay, what's the risk versus benefit of giving somebody this? But yeah, I mean, I don't typically do Valium. Like I'll do a single dose sometimes, but I hate prescribing benzos for people because I think that just puts a bad precedent on, especially if it does improve their pain significantly. There's a very few exceptions to that where I think someone's very reliable and it was like more of an acute thing or something. And I know they have good follow up, but I'd just be careful about that. But that being said, again, anxiety and the fear of the pain returning is a huge component of this a lot for people. And so giving someone a brain relaxer to help sort of relieve that anxiety is also not terrible.
So which one is your go-to if you had to choose one?
I do Flexeril because I think the side effect profile is a little bit safer. I mean, they all have potentials, but it's readily available. So is like Robaxin, so tizanidine is as well. But I think Flexeril has like a little bit less of the sedating properties than a few of the other ones, and people are just kind of more familiar with it. So like patients who have had friends or whoever, like, oh yeah, my friend got that, like I know what that is, versus kind of like a lesser known one.
Gotcha.
And then so opiates, I think a lot of the discussion around opiates and back pain has existed for quite a while now. We're obviously in an era that we are trying to decrease our opiate prescription and use quite a bit. They do have a place for any sort of acute pain, of course, especially injuries, stuff like that. I rarely use them in the ED, even as like a single time dose. It's hard to just say why. That's kind of the art of medicine. Is like you will decide, okay, I think this person is fine to get it and could benefit from it. But most of the time, I try to stay away from it, and I absolutely never, ever prescribe it for any long term sort of use or even medium term. There have been robust amounts of evidence out there to show that it's horrible for low back pain in general and kind of long term musculoskeletal pain. And frankly, this was a big contributor to kind of the opiate epidemic was a lot of prescriptions for these kind of like chronic pain issues. Um,
So no
a lot of people,
opiates.
I'm sorry,
So try to avoid opiates.
I
Definitely
would.
don't be prescribing them, but in rare cases, sometimes we do give a little something
Exactly.
here and there just to get things moving.
Really, okay, so what about the rest of it? And I think this is sort of where, again, we can help a lot of patients in the short term who are likely struggling to see their primaries or see any sort of like orthopedist or sports medicine specialist. And this is where your exam comes into play. Because the nice thing is, all of those medications you can use in the same combination for any of those diagnoses. So a lot of people may ask, like, okay, why does it matter if I think it's, radiculopathy or sciatica versus like facet arthropathy or muscular pain? If I'm just going to all treat it the same, why does it matter for us? So, in my opinion, one is again like giving people a specific diagnosis. And I think that alone just alleviates a lot of their pain and anxiety from it, and gives them like an actual answer. A lot of people just want to know what's going on and not to be told like, sorry, I know it hurts, but I don't know what it is. So there's that component to being more specific. But then, if you can and your system allows for it, getting people a physical therapy prescription slash referral is actually super helpful. because every single orthopedist and sports medicine person or physiatrist is going to be starting with physical therapy for all of these,
Mm.
unless it's like super severe and debilitating and they can't walk or something. But that's again a little more severe in a different discussion.
So
So
even
presuming it's
before getting an MRI, you would probably just do physical therapy first.
yep.
Okay.
Yeah. So in the office, we see these people. Actually, most insurances will deny MRIs until people have undergone 2 different oral analgesics and at least 6 weeks of physical therapy.
Oh, wow.
And the reasoning is actually because it's hard to convince people of this sometimes, but that fixes the vast majority of people with any of these conditions. And so it's hard to be like, hey, as long as you put in the work, show up to physical therapy, do your exercises at home, like this will get better. So the exercises do work, and just trying to harp that on your patients is really key. And we do the same thing from the office. Like you got to put the work in, but it will improve your symptoms. And whether it cures it or not is like that's the next step for us. Like, okay, maybe we just got to make sure that we're being specific. But where you or like as the emergency physician can give them a little more specifics is the physical therapy for the different conditions is slightly different. So that's where being a little more specific kind of helps the physical therapist then say, okay, the doc thinks it's this. I'm going to start my tailoring this program to like exercises for this specific condition. And a
Gotcha.
lot of them do overlap, and they actually do their own evaluations, and they're pretty good at coming up with like, oh, I think it's more X, Y, or Z anyway.
And I know so ideally we're going to be, if we can set people up with PT, we do that. Otherwise, we try to get them in to see you guys who can then bounce them over to PT. Are there certain discharge instructions we should be telling people with back pain? Maybe not exercises to do, but I often say, and I don't know if this is even right, but like, try not to just be bedridden, try to stay ambulatory. But I don't know if you have, like, what do you tell patients maybe to do while they're waiting for their first physical therapy appointment?
Yeah, so you're 100% correct. Lying around is just going to make things worse, exceedingly worse. You'll just like if it's not muscles, or even if it is the muscles causing the pain, you'll just get more stiff and then start to get muscular pain or just worsening pain. So that's not going to help them at all. Um, you actually can give them exercises, and again, this comes down to like your comfort level and sort of what you think might be causing the symptoms. The nice thing is, there's not really an exercise that's going to make something worse or be dangerous. Like the worst case scenario is it just hurts too much for them to do it, and they don't do it. There are several different sort of resources out there, and I kind of use different ones for different conditions. But if you just type in like lumbar radiculopathy exercise, like home exercises, there's the first like 3 or 4 Google results are going to be from different societies or different organizations, and like, hey, here's what we give our patients, and it's like there's a couple of them that are great that have like a list of the exercises and like pictures on how to do them. And they're not necessarily always included in discharge instructions. Some places will have them kind of nicely built into whatever EMR you have, but you can also just print them offline and hand them as part of like their discharge instructions. Say, hey, like even if you can't get into PT or whatever the case is, start doing these. I usually tell people like ideally it's twice a day. Most of the exercises are pretty brief, and you can do everything over like 15 minutes. And like if you can do this morning and night, you're going to be in good shape 7 days a week, but at least once a day, which is what PT is as well. It's not just doing the exercises when you're in the PT office, like you're doing all of them at home, and they're just kind of adjusting and sort of progressing you as you get better at them.
Gotcha. This is great. I mean, I feel very empowered to actually feel a little bit more useful when I see these patients.
Yeah, I mean that's kind of my hope, and again, it was even just for back pain, but all types of musculoskeletal complaints was a big part of my training, and that's how I use it when I still do my EM practice as well, is to try to be more specific, and I think it gives people a lot more relief to have a specific answer than just like I don't know, I'm sorry, it hurts.
Awesome. Thank you.